Hello, welcome to this Collateral Global Conversation. My name is Daniel Hadas, and I am an associate of Collateral Global, and I am a lecturer in ancient Greek and Latin at King's College London. I won't say any more about myself now because there will be a second podcast where I will be the interviewee. Today, I'm here to interview my colleague at King's College London, Dr. Caitjan Gainty. Caitjan is a historian of medicine, and I'm going to ask her first to introduce herself, tell us a bit more about her background and what she does, what she teaches and researches.
Great, thanks, Daniel. So I am a historian of 20th century medicine, and particularly in terms of health and healthcare and how medical systems are developed over the 20th century and the sort of the inheritance that sort of feeds into our healthcare systems today. As you said, I teach at King's, and I run a project called the Healthy Scepticism Project, and that project is really about hearing the voices of people who have been disenfranchised from medicine or who are critical of medicine, and all the different reasons that they are sort of marginalized by medicine, and kind of reinstating them into the conversation to sort of understand their points of view and to see where what they're saying can inform how we think about health and healthcare and how these things are done.
Great, thanks very much. And we'll hopefully have time to talk a bit more about the Healthy Skepticism Project towards the end of this. So Caitjan and I were, like so many other people, very isolated from each other during the lockdowns, but as the world opened up, we sort of crossed paths, and Caitjan gave a talk at the university where we both work, and I sent her something I had written, and it became clear to me that we had some ideas in common. And we've had some private discussions before we got to here, so we both thought it would be very useful for us to put some of our thinking out into the world. And so what I've done is I've prepared some questions which Caitjan has seen in advance, so she's had some time to think about, and we're going to go through these and talk through them. So the first question, something that when we were discussing these matters earlier, Caitjan had said to me is that she was not surprised by the form of response that we had to the COVID pandemic. So that this response, which I would basically characterize as rolling lockdowns and then the rollout of vaccines, putting an end to the lockdowns, was something that she, as a historian of medicine, thought we could expect. And this was very striking to me because I think like most ordinary folk, was extremely surprised by this response. I had never heard of lockdowns, and was just, when this was sprung very suddenly upon the world, was completely bewildered and had no sense of where this had come from and where it was going. So I'm hoping you can tell us a bit more about why you, given your background, were not surprised, why this response was something that we could have expected.
Yeah, well, I mean, just to say that my first feeling was that, way back when COVID was something that was just happening in China, my first thought was that this was going to go the way of, Ebola or Zika or SARS, and be something that we would panic about, but we would keep at a distance. And so, and that means that we would sort of close borders against particular groups of people and all the sort of associated discrimination that goes with that. But the kind of panic around it wasn't going to turn out to be, as warranted as wasn't going to turn out to be warranted. But I think then, and especially as COVID started to, enter Europe, at that point, I thought, okay, so this is going to be quite a different story. And I mean, remembering that one of the more recent pandemics we've had was swine flu in 2009, which was really the pandemic that was not, because it was, not deadly, but inspired a lot of similar kind of panic that it would be here in the country with us and that it would cause all sorts of devastation. It turned out to be much more mild. So there are these kind of competing views of competing ways in which it might not pan out to be, like a real disaster. But I think once it reached Europe, then I started thinking like, okay, so what will happen next? I mean, what's the response that we can expect? And in sort of historically, there are very limited possibilities for responding to a pandemic. And especially because pandemics are not these things that you can predict well in advance and prepare for. The kinds of things that you can do to stop them are these very blunt instruments, and that means quarantine type things. It means, especially waiting out until we get a vaccine. It means things like masks. It means things like social distancing, because really there aren't a lot of other options. So it seemed to me that if there was going to be a response, it would have to be in that kind of non-pharmaceutical sort of way. And of course, I found it sort of personally shocking in a way to kind of uproot and just be sort of like, okay, now we're only staying at home. That's what we're going to do. Like, that's not normal life. But at the same time, it felt to me as though, well, yes, I mean, what else? What are the other options, right? There's really nothing else you can do except do nothing and let it sweep over you. And in many ways, that's, it sort of depends on where you are in the world. But in many ways, that's not an acceptable option, particularly in the way that we sort of think about healthcare now as something that is, every person deserves to, be healthy and be free of illness, and if you're not, you go to the doctor and they make you so, right? So that kind of mentality sort of, to me meant that we couldn't do nothing, and that the only things available would be these very kind of blunt sorts of things.
Right, yeah, thanks. I guess that the sweeping over, the problem is that there's a certain admitting defeat in advance that is very hard for systems like ours to do. I mean, it should be said, I think this is something that doesn't get said enough, is that there are large swathes of the world, particularly I think in Africa, where that is effectively what was done. So the sort of do next to nothing option isn't beyond the range of what humans can do. It's just...
No, absolutely, that's right. And I think, that brings up such an important point about all of this, that the perspective, the way of thinking about healthcare that takes place in the global north is really unique to the global north, right? And I think, there have been some really great points made about the fact that in places in Africa where there have been a lot of epidemic disease in the past, or epidemics have swept through and those diseases have become endemic, they have there's a very different sort of system in place for kind of dealing with these things. Whereas in the global north, we have this kind of terror of things crossing our borders, and this is also where national security interests kind of become, or kind of are indistinguishable with public health interests, right? And so you can see, of course, again, it differs from nation to nation to nation, but I think in the mentality that feeds is sort of in the United States and in Europe and here. The options are really limited. But I think we'll also get on, it would be great to say more about sort of the global situation, but I think that will come out in some of the other questions.
Yes, I hope it will. I think where we've been going takes us very naturally to my next question. So a lot of course, what we've experienced over the past 2 years has been expertise telling us how to understand what's happening, and particularly the expertise of epidemiologists and public health specialists. And the way I've sort of seen it is that there's been a bit of middle ground, but basically there's been two narratives pointing in almost diametrically opposite directions. And the first narrative, which I would say is the majority narrative, if you just count heads among these kinds of specialists who are the relevant specialists, is to say, essentially, this reaction, this lockdown till vaccine strategy is what we do in pandemics. It's what it says, and it's just normal science, as it were, put into action. And then the other reaction from a smaller but equally credentialed group of people of the same speciality, including some of the people involved with Collateral Global, has been to say, this is the opposite of a normal reaction. This is not the sort of thing that you actually find in pandemic planning. We've really pushed the boat out here. This is completely not just unprecedented, but not what's recommended. And there's been a lot of sort of hardening down on those two positions. And so I wonder if you can sort of help us think through these discrepant narratives. Is one right and the other wrong? Is the truth somewhere in between? What is going on with this?
I mean, that's a tough one, really. And I think, you do get these examples in the past of pandemic planning, particularly around flu. Flu is a frequent model for pandemic planning that do look a bit like this. Or else, they do kind of a dry run of what a response will be to a particular disease. And it feels like it's, always slightly disastrous, like the right things don't happen at the right time. In large part because you can't predict the course of a pandemic anyway. But I'm not the right person to say whether one is true or not,
okay.
Right? I think I don't have insight really into how public health people sort of think about these things, and what in their universe is right or wrong. But I think it does point to this idea that there are really divergent views, and there have been for a very long time really divergent views about what public health is supposed to do and how it's supposed to function. And I think that takes us back sort of into the history, that there's a long period in the history of public health where public health is, just overtly about populations and protecting populations in really basic kinds of ways, and then it gets bound up in issues of national security, and then it becomes something about, where you can sort of say well, what are the goals actually of public health response? Are they to prevent disease from coming into a country, so they're about containment outside of a particular place, and it's about border crossing and those kinds of things? Or are they about, what the public has a right, the rights of the public in terms of public health? And I think there just are varying viewpoints within the public health community about which one of those is the right view to take of public health. I find it difficult to, from the outside, I find it difficult to see, a way to kind of parse things that would end up with this is the right way, this is the wrong way sort of scenario, because I think, there's this kind of unknowability about pandemics, about disease, about epidemic disease in particular, infectious disease, that follows it right through the history. And we have talked or sort of emailed about this idea that, in the 1950s or so, there it gets to this point where people are sort of saying wait a second, vaccination hasn't actually made the difference that we thought it was making. But then you also get people who say vaccination is always the answer. And from a historical perspective, from an outsider's perspective, it feels as though the truth is that it's a much more muddled sort of thing, and that even though all of these things are supported by the kind of, our currency of data, in reality, in a way, what they show is the extent to which these things are also driven by differing values, differing understandings of what the right way is to actually, secure the public's health. So I suppose that's not the best answer to the question, but hopefully sort of is, heads in a useful direction.
Yeah, it sets some background for this. I suppose one aspect of this is that it's not just a question of what public health strategy is, but the extent to which public health gets to run their strategy.
Yeah.
Because public health is not the only power in the land.
Yeah.
But where once you make COVID sort of the central problem of political life, then you tend to hand everything over to public health, which I guess also puts the pressure on them to solve it.
But I think it's also very important, to flag this moment in the early 2000s when it just becomes very clear that public health is really folded into national security in these very fundamental kinds of ways, so that disease then becomes sort of an enemy, it's like guerrilla warfare or something like that. And that too, that reframing of epidemic disease really then sort of changes what the possibilities are, right? And what the different kinds of, like, it changes, I think, also the idea of what it is that a public health professional is supposed to do. I mean, it's certainly the case, and I think this is very interesting, that prior to COVID, you would see all the time in the literature this kind of stuff that's sort of like, people are never going to go for a lockdown, so lockdown is off the table. And, or models of pandemic preparedness that are based on flu, where again, they sort of say like, well, we're not gonna, we won't end up doing lockdowns, we'll do testing, right? Like that's sort of the key word, and that testing, and we'll roll out a vaccine, very, very quickly, because flu is a known quantity in a certain kind of way. But I think that, one of the problems is that COVID is not flu. And then, how do you kind of, without knowing exactly what's going to happen, like without knowing, what COVID's going to look like, how hard it's going to hit. I mean, you can try to predict those things and make projections, but you can't actually know. And so all of these questions then become a kind of like, well, which predictive model do you think comes closer? And let's kind of go with that.
Yeah, thanks. I mean, I think that's important. The national security thing is very interesting, and those who are not great fans of the war on terror might think that the parallel is a bit alarming. But I think the flu thing is. I'll get to the next question in a moment. But I think the flu thing is very important because part of this sort of dichotomy that I've outlined of what were the plans before has been essentially people going over documents about flu.
Yeah.
Saying, well, this is not what was recommended for the always hypothetical influenza pandemic. And I think part of the response to that has been, yes, but that's influenza, and this is something new, and so a different strategy is needed. I think that one probably has to push back on that in the sense that, as really your swine flu example illustrated, just because a novel virus is a mutation of a known virus, as opposed to a novel virus, doesn't actually mean we necessarily could predict much better what it was going to do.
Right.
But certainly in terms of the sort of linguistic categories, setting up how people think, I think the fact that it wasn't flu did make a big difference. And I think the other thing that I'll just pick up on what you've said relative to my initial question is the fact that the literature was saying people won't go for lockdowns, so we can't do them.
Yeah.
Which is very different from saying lockdowns aren't something we should do. And that really saying, well, if we could get people to go for them, then maybe we should do them. And I think that does take me, unless you want to respond to that, to my next question.
Well, I do. The one thing
Please
I would just say quickly about swine flu is that one of the things that was so interesting about swine flu is how quickly a vaccine could be produced, right? And that is the kind of comforting thing about flu to some degree, that because it's a different strain, right? But it isn't like starting all over again with a novel virus. At least that's my understanding, right?
Right.
And also that for swine flu was something that had been around before, so that there's this kind of sense that, well, it might come around again. Let's have some vaccines handy for it. And so I think in that sense, flu was a real kind of red herring in a way.
Right.
Because it sort of, it's something that, felt much more comfortable, and COVID was something else entirely. I mean, there's this great document on Public Health England that I think I've told you about this before, that said, it was like the celebration of 100 years after Spanish flu in the early 20th century. And it says, don't worry, we're completely prepared now for the next big pandemic, like that kind of thing. All presuming that the next big pandemic will have to be a flu pandemic, and makes it sound like, it's not really going to disrupt your life, and we've got you covered, right? Which I think is, not at all what happened.
Indeed. And of course, there was enormous pushback early on in the COVID outbreak about the idea that one should ever compare it to flu.
Yeah.
I think, and part of the sort of secure language about flu explains that. I mean, I suspect there's some limits to there's a gap as so often between the reality and the model on this, in the sense that on the one hand, I think that influenza vaccines' efficacy is somewhat cloudier than public health people tend to say. And conversely, my understanding is that there were functional coronavirus vaccines for animals, so there wasn't really a lot of doubt within the immunology community that some sort of vaccine would be cobbled together. But definitely the difference in categorization, I think, made a huge difference to the response. Okay, so moving on to my next question, which is sort of part of the same complex of problems. So something that I, and not just I, have found very bewildering about the nature of the COVID response is what I would tend to see as the failure of authorities to carry out cost-benefit analysis. And I would say that's cost-benefit analysis, firstly, for society as a whole, and then secondly, even for medical systems. So, for instance, we are now starting to see more and more all these factors that many people predicted about the various knock-on harms of lockdowns in terms of, for instance, children's education, people's mental health, et cetera, et cetera. And then also, even in terms of healthcare, there are clearly stresses that have been put on the healthcare system specifically by locking down and people largely not using it or using it much more than less than they normally would for a number of years. So what puzzles me is that on the one hand, I think of the response that we had to COVID as essentially, at least in its language and its sort of public presentation, is essentially technocratic, that we sort of have the experts and the scientists and the apparatus of state and the command and control structure jumping in and trying to solve this problem and saying, we're going to beat this and we're going to control it. And yet, I think of technocracies, and particularly healthcare technocracies, as very focused on cost-benefit analysis, not just as a sort of philosophy, but as something you actually put spreadsheets together and do. For instance, I know that the NHS has this whole concept of quality-adjusted life years, and when they decide whether to improve treatments, they don't just go into an emotional, we have to save lives thing. They put it into an equation and make a decision. And so I guess the question is that, is it, in your view, how do we think about what happened with cost-benefit analysis? Was it abandoned? Was it diverted? Was it seen in some way that those of us who think it was abandoned aren't seeing? How useful is it as an idea to bring up here?
Don't you think that, when it comes to sort of thinking about health, cost-benefit is acceptable in particular areas, which are less about whether, less about what's an acceptable number of people to die, and more about, as you're saying, sort of quality-adjusted life years. I think that there's, one of the things that happens over, as healthcare systems develop, is that they move from really something that is a kind of population-based thing that is much, kind of more in this kind of cost-benefit sort of way, to something that is a service that's provided to individuals to benefit their health, right? And so if you're talking about something, within healthcare that is, sort of comparing comparable, sort of two cancer treatments that may be comparable, and thinking about one is going to save 90% of people and the other is going to save 85%, and that one is much cheaper, that's the one you go with, right? Those kinds of choices are okay. But when you're talking about in this instance, what is kind of was initially from the get-go put in terms of, people are going to die from untreated disease or from this disease unless we put these measures in place, then it becomes a different sort of issue. Or do you not think so?
I think you're definitely right in some basic sense that people are going to die short-circuited. A lot of the sort of more cold and calculating technocratic ways of thinking about it. I guess the two things that I'd slightly push back on are, firstly, slightly push back on his academic speak. Firstly, when you take with your cancer parallel, you say, well, if we use this treatment, 85% of people will survive or die with it?
Survive. Yeah, let's just say that. Yeah.
Whereas if we use this one, okay, so in other words, 15% of people will die. Whereas if we use this treatment, 95% will survive,
Yeah.
and so only 5% of people will die.
Yeah.
But we're going to do the 85% because it's significantly cheaper.
Yeah.
So, I mean, you could frame that also as we're killing people to save money.
Yeah. Yeah.
Which is.
But that's not how it's framed, right? Because every person still has an 85% chance of surviving, right? Which feels a different thing than saying, well, we're not going to do lockdowns and we're just going to kind of, let things roll, right? Like you can't do nothing, I think is like
right.
this kind of, and so the cost benefit analysis has to take that into consideration as well, right? And that, I mean, it doesn't mean that this was a rational way.
No, I understand you're not saying that.
To go
we're
about
just trying,
this, yeah.
No, we are, to be clear, we're just trying to understand how
Yeah.
this thinking worked. Caitjan
Yeah.
is not an apologist for it.
But I do think, I mean, it's very much I think this is one of the things that is really interesting about healthcare systems, particularly, like the way that they develop, these kind of cost benefit things are hidden, except when they come out, so in the US, the kind of consideration that they might have a NHS style healthcare system immediately prompts responses of like, there will be death panels,
Yes, the death panels.
Right? Like that kind of thing. Yeah, the Sarah Palin line. And I think like at that point it becomes something, that's the trump card in a certain kind of way. And I think it may have happened the same way here. And I think this is always what's happening in terms of healthcare. I mean, it's like you read the histories of the NHS, and there are very interesting questions about like how much money do you spend per person in order to make sure that they have, X number of years of high quality life or whatever, whatever the case may be. But that's not something we really hear a lot about. And instead, the way in which we interact with healthcare and the way in which we understand health, which I think is really problematic, is this kind of like, well, basically no expense will be spared to keep you alive because life matters above all else. And I think that's that's been the discourse here. And I think that really, sort of turned it into something that you can't make you can of course do a cost benefit analysis, but not without, hearing back from critics like, well, these are all the people that you're going to kill. And I think, unfortunately, it feeds into a way of thinking about healthcare that we actively prop up when we think about, like personalized healthcare in regular time, like when we're not thinking about these other kinds of issues, such that it becomes very difficult in a moment where maybe a cost-benefit analysis is the right thing to do to actually do that cost-benefit analysis.
Yes, I think you've made some very important points, Sarah, which I'll just pick up on a bit. So one thing I think is that, I mean, I have been saying sort of, well, why didn't we do this cost-benefit analysis? We do this, but it is true that is generally done behind the scenes, that health authorities don't go around saying, well, we're not going to do this treatment because it's just too expensive and it's likely X number of more people will die. So once I think health policy becomes not at all behind the scenes and it's the focus of entire nations, it was much harder to use any of that language. And then the other thing, I think, well, two more things. What you've been saying about how this is, and this is something I think about all the time, is how do the things we do, how do they fit into existing trends? That yes, this no expense can be spared to keep people alive, and just being alive longer is a unconditional good, has very much dominated a lot of healthcare developments. I mean, I read about sort of, say, these sort of programs to detect various cancers early, and there's certainly a view that the evidence is that these programs don't prolong life overall, but and some of them don't necessarily even stop you getting the cancer they're testing for, but the sort of discourse of, well, if you don't do this, this person can get cancer and die, and if you do it, they won't, drives the machine forward.
Yeah.
And just to sort of frame the whole thing a bit, in terms of what you're saying about why this analysis was abandoned, one of the things that's stuck in my head is at that sort of those few, maybe a week and a half in the UK before the UK adopted the same strategy that was being embraced throughout the world, and we were actually fairly early adopters of it, but there was this moment where we weren't going to do that, and we were going to follow something more like the focused protection strategy, the herd immunity strategy, all these words that became taboo, particularly herd immunity. But one of the things that Boris Johnson said when he was presenting the strategy to the nation is he said, a number of people will die before their time. And even if one doesn't think about what before their time might mean, this was a sort of whole different philosophy where you say there's only so much we can do and shit happens, as it were.
Yeah.
And that, I think, was essentially a sort of way of saying to the public, we have, this is how a cost-benefit analysis works.
Yep.
The cost of doing this is that some people are going to die before their time, but there are benefits, and if you weigh it up, but it couldn't, or it didn't fly.
Yeah.
It was just not ultimately possible or he didn't feel it was possible, and many world leaders didn't feel it possible, was just to look their populations in the eye and say, some people are going to die of this, and there's nothing we can do about it.
Yeah.
And that, I guess, short-circuited the cost-benefit.
Yeah, I think the truth is that's exactly what happened anyway, right?
That is
maybe
exactly
not to the same extent, but that's what a pandemic is all about in a way, right? Like that there's going to be many, many, many people who will die before their time, if that's the phrase, and that's just, but in some ways it's such an interesting thing because this is like, that's true anyway. Right? And I think we have this kind of view of healthcare as this thing that's going to prevent that from happening in regular time anyway, when in fact it doesn't at all. And we kind of rationalize away that idea that people are going to die of cancer, they're going to die in car accidents, they're going to die of all sorts of different kinds of things before their time. Mm-hmm. But those are all, that's kind of like we don't talk about that either, right? Because that would destroy the kind of illusion that medicine and healthcare systems actually do, mean that everybody lives, 100% of the time to the, their time. Whatever
yes, the reality is that when you're born, you're not actually handed a contract saying you're guaranteed X number of years, and if you don't get them, you may sue the government.
Yes, right, exactly.
We seem to sort of think like that is in fact the case.
Yeah.
Great. Shall we move on to the next question?
Yeah, sounds great.
Okay, so this takes us into a related but somewhat different field that I also think is very interesting. So one of the rare places where the critics of the COVID response that we've had of the lockdown plus vaccine response and the people who think it was essentially the right idea, no one seems to think it went perfectly, but there are people who basically think we did the right thing, not well enough, and people who think we did the wrong thing.
Yeah.
But one place where they do seem to be able to find common ground, or at least use the same language, is in deploring the fact that the response was politicized. So what should have been a scientific and a public health response, and one led by evidence and health policy, was taken over by politics. And probably the single most common narrative you get about this, at least on the among the opponents of the response, well, it really goes both ways, is that in the US, because it happened during the Trump years and because Trump was such a polarizing figure, you'll get people either saying Trump made it all go wrong, or people on the other side saying the reason that we locked down is because Trump said we shouldn't, and it was just taken over by politics. But there are various ways in which the narrative says it was taken over by politics. And I tend to view this as naive, in the sense that I don't believe, firstly, that health and politics can be separated in general, and secondly, that when you have something that is such a an event that's affecting the whole population, I mean, in as much as, yes, not everyone was going to die of COVID, but everyone was and is going to get COVID, and it's a novel virus, so it affects the whole population, it affects these key infrastructures, and there's no way that it's not going to be politicized. The idea that you could set something that important to public life aside from politics, I think, doesn't make any sense. So, I guess, do you agree? And you're nodding, so I think you do.
Yes.
But I guess what I would say is then, could you tell us a bit more about the sort of historical background to this idea of the politicization, the insertion into politics of health, and any thoughts you might have about why the COVID response took, as it were, the political form that it did? And if you want to touch on this, the burning question, I think, is why is it that, roughly speaking, the left embraced the sort of maximalist lockdowns, and in as much as there was pushback on it, not all of it, but quite a lot of it came much more from the right,
Yeah.
at least in the US and in the UK and the
Yeah.
Anglosphere, and I think in a number of other countries.
Yeah. Okay. That's You'll prompt me though, right?
Yes, of
We'll
course.
keep. Yeah. So, I mean, I think you're absolutely right. Like, it's kind of ridiculous to. I mean, I would go even further than you have, I think, and say that, science is always political, right? Medicine is always political, and in some ways, how could it not be? I mean, I think particularly for public health, like as soon as you make it the business of the government to, see to the health of a nation, it already becomes something that is, deeply political.
I mean, health is a major issue in politics in the UK and the US.
Yeah.
Every election cycle. right?
Exactly. Yeah. Yeah. And I think, I mean, what's always been really interesting to me are conversations about the NHS. I mean, not having been brought up in this system. I think it feels stranger, I suppose, to me than it would had I not come, from the US. But this idea that the NHS has also, suffers as a result of like political fights, right? And that it is, but that it is itself sort of a pure service, like really the embodiment of like everything that's good about the country. And I've never quite been able to see it that way, because it seems to me that it is, health is political, but the kind of, it is undeniably like these are not separate things, right? Like these are all bound up together in very particular ways. And so I think it's a dangerous thing to do to from the outset that we've done, but from the outset to kind of say like, well, there's science and objectivity and data and evidence over here, and then there's politics over here. Because I mean, the way science is, that kind of confers onto science this kind of status of being a teller of truths that politics will or won't act on, and that's just it's not accurate.
You've said something that I just want to bring out because it's fascinating. Which I mean, for those in the UK, this will I think resonate. If you're not here, maybe less, but that myth, as it were, of science as a pure and objective, apolitical body has been transferred from science in the abstract to the NHS as a thing.
Yeah.
And this is part of how, as you're saying, and to save the NHS was one of the 2 or 3 most dominant narratives that drove lockdowns in this country, and then drove the transfer to towards vaccine mandates, so that we pulled back, save the NHS. And this was dependent on this whole idea that there was this perfect NHS, which isn't the one we ever quite have, but that both politicians and citizens have a duty to somehow bring into being.
Yeah. Yeah, it was that slogan, right? Stay at home, protect the NHS, save lives, or whatever, right?
Yes.
Like that, or whatever it was.
Stay home, saves lives, protect the NHS,
Something like that. Anyway, I mean, but that kind of sentiment. I mean, that's one of the reasons you lock down, frankly, right, is to protect your infrastructure. And, the NHS is obviously a part of the infrastructure, and the same logic, in the US to some degree also. But I think one of the things about the kind of this politicization is that really it takes us back to these various moments over the Cold War. This is what people will say, or one way of sort of telling this history is to say that maybe science was something that was sort of its own separate thing, medicine was its own separate thing, but once it gets, becomes a part of this network, this kind of network of like experts and information over the Cold War period, where funding comes from the government and into these various things, then you get a very different, you get a very, it's undeniable, I suppose, at that point that all of these things have to be political in some kind of way, because they are not these entities unto themselves. They are always interconnected with all of these other things, pharmaceutical companies, universities, the government, like all of that kind of stuff. And so to say that they are these like rarefied spaces, or these kind of like ideal kinds of things that exist separate from the politics that is everywhere otherwise, it has just never made very much sense to me. And
yeah, I mean, I suppose in as much as it does, it would be for a much earlier period in history when doctors are basically working on their own in their own subculture. Although even then,
even then, I mean, but exactly,
no, I mean, I certainly one of the things that I've done fairly recently is actually listen to Eisenhower's famous military-industrial complex speech rather than just knowing the one sentence.
Yes.
And it's very striking that a lot of what he says you can sort of replace military with medical, and it fits very well.
Yep.
And that also indicates, I think, something important, which is that stream goes both ways. It's not just that politics influences science and medicine, but the science and medicine have a hand in what politics is.
Yep.
So, I mean, I think that probably we'll agree that it's rather than lamenting the politicism, this is a terrible word, rather than lamenting the fact that medicine has been made political, we have to accept that as a ground fact and then say we need a better politics, I mean, it's not even a relationship between medicine and politics because they're together, but so we need a better politics, including a better medical politics, rather than saying we need to just move that out from that sphere. I'll just say something briefly on this because it's, which is that the sort of famous country that did something different in the West is Sweden, and a point that's sometimes made is that Sweden deferred from, I don't know about all, but many other Western countries, and that there was a sort of constitutional setup where essentially the public health bodies just got to decide without interference by politicians. Now, I'm not an expert on the Swedish constitution, so I can't quite say how true that is, though certainly it's something Swedish politicians and commentators say. And it is probably true that it was a factor in Sweden following a more sober response, that there was more of a free hand for the public health authorities, for Tegnell in particular. However, I don't think that it's right to then say that means the Swedish response was depoliticized. That's still just a political choice. It's just a different one.
Yes, I mean, the contingencies to take into consideration are different, and therefore maybe more choices become possible. But I think your interpretation is right,
and I mean, who knows what would happen if we had just, in this country, said, Sage just gets to decide everything, but it's not necessarily the case that means we would have done what Sweden does, at least. Different, clearly, even if it's public health working on its own, as much as that's the thing, they still...
I mean, it's also interesting to think, like, well, of course, all of these different places have their own politics, right? Like, and that's also a confounding factor, right?
Okay, so you were saying that not every country has the same politics, and that reflected something that I understand to be the case, which is that in Sweden, the polarization was different from what we've seen in the US, UK, and other countries. And that was the sort of tail end of the question that you're answering, which is, do you have any thoughts on why the left and right tended to split in the way that we've seen they did?
I mean, that's such a difficult question. I mean, it's a really interesting thing to me, because, this was the position of the left, right, for a very long time. And at this moment, over mid-century, the left was in this position of really challenging authority, challenging these kind of institutional structures. And that critique, in some ways, has sort of disappeared, or even the possibility of articulating that critique has sort of gone underground, I suppose. And that it's become sort of, I mean, that the right has instead inhabited this position. I mean, I think it's a really interesting thing. I don't think I have a good answer to it, except to lament slightly that we can't have these more nuanced conversations about it anymore, because there isn't this kind of more radical line on the left that's, like has these really interesting sort of intellectual roots. That has really gone away. And of course, at that moment, it's the product of so much that's happening over mid-century. But where it's gone exactly, I don't know. I mean, one thing that's really interested me is thinking about people like Robert Kennedy Jr. and his campaign against vaccination. He's like this very, kind of left, like dynasty family kind of thing. And is saying these things that, maybe in the 60s, 70s would have been acceptable, and grows out of these kind of concerns about, the environment and all these other kinds of things, but now are just, like a kind of embarrassing and strange, and nobody knows what to do with him. And I don't really know his work that well, but it strikes me that he's sort of an interesting example of what happens when you do articulate something that was, something much more commonly articulated in that period. What happens when you do that now? Well, it's, like people try to kind of, like sweep it away, or just, avoid having to talk about it, or just condemn it as, crazy.
Right. Yeah. And that's right. I mean, I think he himself probably is, some of the things he says are very crazy, but certainly it comes from a tradition of radical critique that is,
maybe it doesn't, but I mean, it could. Exactly. It could anyway. I don't know him, so I can't say.
And yeah, I mean, I don't have an answer to this either. I mean, certainly in countries where there were right-wing governments with left-wing, who had to take charge of the COVID response, the political sort of mainstream left's radicalism basically took the form of saying you need to do more of what you're doing, rather than the sort of more elaborate critiques. Certainly, the national security parallel that you raised earlier does put the question in sharp focus, in that one did associate the left, even within the last 2 decades, in as much as there was a strong critique of the national security state. It did tend to come from the left. But it does feel like, at the very least, they were blindsided by the health security state that was growing at the same time, and were much, much less able to critique that. Why the right felt differently is then not obvious, but certainly to some extent, I think the right has become the less institutionalized party, and therefore more able to critique the institutions. So we'll move on to something else that has been does relate to, I mean, Robert Kennedy Jr. and the left and the right and all these things, an extremely, as it were, burning issue, which is the question of vaccine mandates, vaccine passports, the various and varying policy measures that states have launched and in many cases taken back, and then it's sort of a moving scenario, but they're by no means completely off the table in every country. But so the use of legislation to make people get vaccinated. And I'm going to ask you 2 questions about this. My first question is, well, the background observation is that unlike lockdowns, unlike stay-at-home orders, and you can only see your cousin once a week and all this extremely strange stuff, vaccine mandates in themselves are not a novel thing in medical practice. So I'm hoping you can give us a sort of brief sketch of their history, and then just some thoughts about how the COVID mandates fit into that history. Are they just more of the same? Are they somewhat different? Where are we at?
I mean, I think that, the history of vaccination is so interesting, because for people who work on the history of vaccination, vaccinations, don't come off as well as we would ordinarily, think they should be. And a lot of that has to do, if you go back sort of to the late 19th, early 20th century, and even earlier than that, really, that vaccines are strongly associated with colonialism. They're strongly associated with government authority. But you see this happening, quite often. You see vaccines as preferred because they are very efficient. And that's a great way, it's something you can do quite easily, and that makes them a really great piece of the public health arsenal. But you also see them being used in a variety of contexts in either colonial or just just after, what's the word?
Post-colonial.
Post-colonial. Yeah, that's it. These kind of contexts. And where they are used as ways that that you can use a vaccine much more easily than you can improve primary health infrastructures or whatever, or that giving somebody a vaccination can stand in for whether or not it's a vaccination for something that they're actually worried about, a disease that they're worried about. It's something you can do and then say that you've done it, and then you sort of move on. So vaccines have this history of being, fairly problematic in that kind of way, because they are these real tools of these empires. And then you sort of fast forward, and they become a key, and for some of the same reasons, efficiency and things like that, a key to kind of infrastructures, public health infrastructures more generally. And again, you do always get the kind of push back against vaccine mandates, but vaccine mandates are also these things that are really sort of, again, like very easy to put in place, because all you have to do is get a needle in somebody's arm, right? And so I think that they're valorized in a particular kind of way for those reasons. But I think one of the really interesting examples for me about vaccines and their use are the eradication campaigns. And this idea that after the smallpox eradication campaign ended in the, I think it's the late 60s or early 70s, there's this kind of recognition that this is not the right thing to do. We can't be using vaccines in this way because it means that we can't do all of these other very important things for improving health. Nevertheless, there becomes this push in the global context to continue with these eradication programs, because it is for all of these reasons that have very little to do with whether the vaccine, the polio vaccine, is the next real campaign, whether people actually need polio eradicated, or whether it can continue to be an endemic disease that, like so many other endemic disease, people live with.
Right.
So, against that kind of backdrop, you get, and of course there are examples everywhere of people resisting vaccine mandates, and these key examples of, the way in which it's about government overreach, and they can be very discriminatory, so that the people who are pursued for vaccination are people who are poor, or people who are, like these kind of marginalized communities. And so they become deeply problematic in that kind of way as well. But that's something that we don't, again, like part of the appeal of vaccination has become the way it fits so well our triumphalist sort of narrative of medical progress, and the idea that this is such a simple way of eradicating disease. It's very much like penicillin, take a pill and you're completely well again, right? That really lends itself to this way of understanding vaccination as something that is a no-brainer, that we should do and we should mandate, and everybody will agree to that, because why wouldn't you?
Right.
It's an obvious good. And so I think that history of vaccination really helps to kind of illustrate or kind of illuminate the way in which we understand vaccine mandates now, and the way in which we then sort of talk about people like Andrew Wakefield, who really was running a kind of fraud scam type of thing. I mean, like, it seems like that's really clear, but he hits this kind of nerve because he's, we're talking about a mandate, the measles, mumps, rubella vaccine, that people are, wary enough. I mean, they're not wary of that vaccine in particular, but they're wary enough of like the notion of mandate that make it explicit and bring it out into the world. And suddenly you can, you get this kind of backlash. So we get those kind of like spurts, where people get very concerned about mandates. But I think the COVID vaccine mandate, like one of the things that's so interesting about vaccines is that you need a very high level of participation in order to actually make them work as they should, right? They can't bring a pandemic to an end if only 50% of the world actually takes them. or has them injected into them. And that means then that we're back to this question of what is the right way actually to think about in a global context how we address this kind of disease, right? Or this kind of in our case, this pandemic is the right thing to do, to kind of say everybody get vaccinated, but that's never going to happen, right? That's not.
Right.
It's not reasonable
Yes.
to think that 95% of the world is going to get vaccinated.
This is an incredibly important point.
Yeah.
Because there was this sense, I guess, that, I guess the obvious problem with COVID vaccine mandates is that once it became very clear the vaccine didn't stop transmission, it was very, very hard to track exactly what they were supposed to accomplish at all. But even leaving that aside, there was this vision that you could probably get everyone in country X vaccinated, a mix of mandates and public pressure, but that doesn't actually eradicate a disease. And if you start saying, well, are we going to get everyone in the Democratic Republic of Congo vaccinated for COVID with a program that apparently requires free shots? It's completely delusional.
Yeah.
And then, so in that sense, this was going nowhere.
I think the other thing is that, people's health contexts differ dramatically, which is sort of what you're pointing out. And that, the stakes around a vaccine mandate or an eradication campaign in parts of Africa, I suppose, the politics there are quite different. We've as part of this healthy skepticism stuff, one of the things that we've talked about is people coming from Nigeria who have very different views about vaccination, and one of the reasons is that they know that they are the guinea pigs for so many of these pharmaceutical kinds of things that, I was chatting with a colleague who said that people refused to take the vaccination if it had been tested in their country, right? They wanted one that had been tested elsewhere, and then it would be acceptable to kind of take this as a vaccination. So there are all sorts of reasons why you might want to resist a mandate that don't necessarily have to do with what you believe the vaccine is capable of, or whether you think there's a microchip in it or something like that, but has to do with the politics of the global politics of vaccination. But I think the question I've always had about this notion that we could do a global mandate.
Can I just stop you for a moment? Because
go ahead.
there's something I wanted to say that connects to what you were just saying about your colleague and talking to people from Nigeria, is that someone I was in touch with during the early stages of the first lockdown was a lady from Congo, from the Democratic Republic of Congo, and she was saying to me, they're going to roll out this vaccine, they're going to make everyone take it, and they're going to make my kids take it.
Yeah.
And I said, no, that's not going to happen. And it turns out that she knew something I didn't.
Yeah.
Sorry, but I interrupted you.
Well, and what was it actually that I forgot? That reminds me of this really important other piece, is that in a place where COVID has not hit as hard, right? There's also this kind of question, which is a perennial question, I think, for in anthropology and sociology and those kinds of circles, is does the global South have some duty to care for the global North, right? So that if you live in a place where COVID really hasn't been that big a deal because maybe you have a younger population or whatever, whatever the case may be, you're taking a vaccine just in order, and this is the way one person I was talking to put it to me, just in order to allow the people of the global North to kind of breathe easy and travel again and go about their business. And it goes into this kind of narrative, or this question that's come up quite a lot, and also in the medical humanities, that, does the global South have a duty to care for the global North? And if so, to what extent and why?
Right.
And I think that's a really important piece of it. And if you were, it's very, and of course, public health is a very local thing, and that's something that I think has become really clear that, so in our particular local context, maybe you want to get vaccinated for any number of different kinds of reasons, or maybe you don't want to get vaccinated for any number of different reasons. But that is a world away from what somebody in another part of the world is going to be thinking about when they're thinking about sort of the cost benefit of being vaccinated. And that, of course, in turn has to do with the politics of global health more generally.
No, that's a very interesting way of flipping that narrative, because of course one tends to sort of hear about how the incredibly generous Western NGO government aid complex is coming to the global south and saying, here's a wonderful new vaccine, and leaving aside the polio and so forth, which I think certainly the cost benefit is different, but that the same story was adopted for the COVID vaccines. This is something we have to do for the world. Say, well, why are we actually so keen on putting however many billions into vaccinating everyone in Nigeria? Is it really to save Nigerians from COVID, or is it to say, well, X number of Nigerians are going to come to the UK, and X number of people from the UK are going to go back and forth from Nigeria, and our plan to actually wipe out COVID in the UK is only going to work if we vaccinate Nigeria. So that's really might be more of who we're doing this for. So I think that's a great point. So so my second question picks up on something that we've discussed a few months ago, which is that you said to me, I'm just hoping you can explain this in a bit more detail. You said that you found the idea a bit odd that vaccine mandates were sort of an entirely separate thing from the rest of our healthcare, that in fact a sort of mandate model was built into a lot of how we think about healthcare in general. And I wonder if I understood you correctly and what you meant by that.
Say more about
Okay, so I mean, as I understood it, there's an idea that's like basically healthcare is choice, that you feel ill, you decide whether or not to go see a medic. When you're there, then the medic says, this is what I think you should do, and these are some other things you could do, up to you. And then you make a series of choices, and it's just sort of you, the expert, and there's a free relationship. And that there's a radical break with that when we come to vaccine mandates, where suddenly it's the medic knocking at your door and saying, you are now going to take this shot whether you like it or not. And so what I'm hoping you can say is that perhaps this actually isn't as true as it seems, and that there's much less choice and much more sort of medicine by authority as part of the overall paradigm. Do you think that's true? Or?
I mean, I think it's an interesting question. I mean, I think there's like the mandates are the kind of public health arm of things, right? Like, and that again goes to this idea that what is the goal of public health? Well, in some ways it's a national security goal, and therefore what you're looking to do is to protect the population, and that's what makes mandates acceptable in that kind of context. Whereas, and of course the whole point is that if you don't get vaccinated, you're not just endangering yourself, you're endangering people around you or whatever, right? Like that's kind of the way that it's kind of narrated. But within healthcare, you're right, there is this, at least the mirage of choice that you're given very particular, here are here's your problem, here's a solution, you can take it or leave it to some degree. But there is, of course, something, that there's something about the power of medical authority that will, for most people, probably mean that you will take it, right? That there's just a kind of, but I think like one of the, part of this healthy skepticism project has really been about rethinking or thinking about the way that we do healthcare more generally, and kind of thinking like, okay, in some senses there's a choice, but in other senses there's not really a choice at all. Of course, that's explicit in certain ways, that if you have a child and doctors decide that child is dying and there's nothing to be done, you have to fight a legal fight in order to keep that child alive, or else, and more often than not, it fails, and the state has an interest, has the overriding interest in that, what happens to that child. So of course there are those kinds of things, but then there's also the idea that the way that we do healthcare constrains already, or is constrained by the way that we have defined health, so that only certain options are possible, and other options are things that don't, that are like, herbs,
Right.
like these things that are sort of like at best sort of alternatives and at worst, like just like charlatans and, people peddling all this other kind of stuff. And if you think about sort of the early century medicine, one of the things that's so early 20th century medicine, one of the things that's so interesting about it is that medicine is really a marketplace. And there's all sorts of different kinds of things that you can choose from for good and for ill. And that's the kind of thing that we have completely done away with, right? The streamlining and industrialization of healthcare systems means that there really are only a particular set of right answers to any particular kind of question. But I don't know if there's maybe something more to it than that. When we talked about it last time, I just can't remember.
Yeah, so I think there's a little, well, just sort of picking up on some of the directions you're pointing in. There's a sort of, in my view, nightmare model where we move from saying, because there is something specific about vaccines which has to do with herd immunity, which, as you say, can actually be as I think it, has revealed itself to be with COVID, can be this actually goal you're never going to get anywhere near. But there is a specific case where you say, we mandate vaccines not just because they're good for you, but because we want to achieve this specific thing, which is herd immunity. So how did we wipe out smallpox? It's not that everyone's vaccinated so no individual can get smallpox. It's that you vaccinate whatever percentage of the population, and then it can't circulate anymore, and then it dies. And so this becomes a sort of ideal that you can do this with other viruses. And one thing I learned not that long ago is that you can actually get smallpox more than once. So the vaccine in itself isn't provided, I think, like 15 years of protection, but it wasn't just vaccinating you as an individual that was going to guarantee you were not going to get smallpox. It was this extremely high percentage of the population.
Yeah.
So that pushes towards mandates, or even if not towards mandates, to these sort of extremely pushy campaigns to get everyone vaccinated.
Yeah.
But I think there's then this sort of nightmare vision where you start saying, well, we need to do this for all these public health goals because it's good for you, and also because we need to protect the health system by making people be healthy in this or that way.
Yeah.
I don't think we're there yet. That's something I worry will be the next rationale for pushing for COVID vaccine boosters. Particularly in a country like this, where we say, well, it reduces, where we have a public healthcare system, we'll say it reduces disease. What do you mean you don't want to reduce disease and be a burden on the system?
Right.
What I think we do have, and this is of course not mandates, and it's not the same, but I think it's a sort of microcosm, is that the idea that if you're unwell, and particularly if you're seriously unwell and are facing this sort of condition that is either going to basically kill you or involve a sort of a life dominated by medicine, that you have this responsibility to not to society as a whole, but to your family, to your loved ones, to your immediate community, to sort of submit to this medical, extremely prescriptive and interventionist regime. And so, if you say you have a quite dangerous cancer, there's a basic expectation that the right thing to do is to put up with whatever is going to come down the pike in terms of these very, very brutal treatments. And it's not to say everyone does that, and obviously it's not a question of judging people's choices, but it's just to say that there is a sense that, this is the fight you've got to fight. You've got to fight against cancer, and you've got to do that for yourself and for your people, your family. That is the brave and stunning choice, is the choice to say, okay, doctor, fill me up with chemicals and radiate me and make my life hell for the next 3 years. Okay, so this is something that's kept coming up in our various questions so far, but maybe we could focus on it, is the idea that, which I've heard from you, so I hope I have it right, that the modern healthcare world involves a lot of centering of this idea of health infrastructures. So I guess, could you tell us, firstly, sort of define this concept, tell us a bit about how it developed, and how it influences how we in fact experience healthcare in general, and in particular with regard to COVID? I
think there's a great way to think about this history that just like, industrialization that happens over the 19th and 20th century happens in all of these different areas, so too does it happen to healthcare. And as I said, in the, to a great degree in the US context, to a lesser degree in the UK context, where things kind of happen on a speedier timeline, the early 20th century is still a moment of medical marketplace. And it's all of these kind of, small business owners in a way, right, who are saying like, here's my version of a cure, and these different sort of medical sects all sort of competing to be the ones who will, kind of ultimately win out as the purveyors, the most popular purveyors of a particular kind of cure. But as industrialization sort of hits, you see increasingly these attempts to streamline healthcare along the same lines, and very quickly it moves from something that is, like anybody and everybody can be a healthcare practitioner to only particular people trained in a particular way can do that. And you get lots of kind of spillover from industrial context, so that efficiency becomes a watchword, productivity, the production of a uniform kind of thing becomes really important. And really what happens is medicine becomes sort of bureaucratized, and the key pieces of medical practice become more something that is understandable in terms of data, in terms of crunching numbers, in terms of producing, producing and disseminating things that can reach, you sort of get this trade-off between like personalized care, but maybe somebody, who has nothing really to offer you except like a nice conversation, with a dissemination of very uniform, very particular kinds of remedies that are, produced in a way that not only, represents like the best, or the best cure is one that can be packaged and sent out, right? So that becomes an important value within medicine. And that sort of continues on and follows this kind of industrial sort of trend. And indeed, by the 1960s, the radical medicine movement is pushing back exactly against that and saying like, this is industrialized medicine. What has industrialized medicine done for us? It's, turned us all into essentially the same person. It's depersonalizing, and it's created, by creating standard remedies, standard units. It's also created of us a kind of standard, so that if we don't conform to whatever that standard human looks like, then, it's on us when the standard remedies don't work as well as they should.
Right.
So you get this very kind of familiar model from other parts of, from other aspects of industrialization. And then that sort of continues on forward. And there's this great, I was just doing research for this other, this little essay that I was writing about computers and data within medicine. And I found this, this person who describes medicine as fundamentally an information technology endeavor, right? That's it, actually, what it is more than anything. And I think that's actually one of the truest things I've heard, that the kind of medicine that we then inherit is this medicine that is very much about this kind of bureaucratic turn, much more so than we think, and about sort of number crunching, and much less about sort of activities of caring, or also, kind of actual, even if you have a face-to-face interaction, the diagnosis that you give somebody is based on data crunched behind the scenes in order to say to them, well, your symptoms fit this paradigm, or your blood work shows this, and so therefore this is, we have now decided that this is the disease that you have. And so all of that is this very kind of, this very interesting process that kind of drops us off where we are now. Sorry, I forgot why I'm talking about this.
Just two things to pick up on that, because I think it's just fascinating that, first, I love the idea that to some extent it's not just that medicine becomes industrial, that there's sort of standardized practices and giant factories making pills, and but that we ourselves as patients become basically industrial objects.
Yeah.
And the doctor is like a guy on an assembly line where everything is supposed to be the same, and it's just do the same thing as they come in. And then what you were just saying about how the aim of the sort of patient's job is to fit into a statistical model. It's particularly striking when you get to mental health, which in reality is extraordinarily resistant to the sort of either, the experimental model of finding biomarkers for a condition, but also actually categorizing things by symptom descriptions. And nonetheless, this whole apparatus is created where you have sort of checklists of symptoms. It's like, okay, you have this diagnosis for which we have this treatment, all of which is an extremely shaky edifice, but it's made to fit the industrial model because that's the model we have. Now, the part you haven't answered is can we use this, what you've just been describing, to help us understand the specifics of what we've done with regard to COVID?
It kind of, one of the things that happens is even though medicine gets more industrialized, it also retains a rhetoric of being something that's very personal and caring. And I think, we see that in places in terms of COVID response. It comes back to the kind of cost-benefit stuff that is very much on the industrial side. And actually, I think that to kind of like just go off on a slight tangent, but one of the things that you have to say about industrialized medicine is that for an industrialized society, it's a good fit, right? And it actually works really well in a lot of different ways. So just in itself kind of pointing out that its industrial trajectory is not necessarily a critique. And I think
it's not all bad, right?
Yeah, I suppose in a way. I mean, I think the other thing that's interesting, even about sort of that you brought up about sort of mental health and is this like horrible diagnostic and statistical manual, right? This thing that tells you here's the disease you have based on. But one of the things that's interesting about it is that, sometimes that model works perfectly. And it really gives you this sense of that there's a kind of call response kind of thing going on here. There's like, health then becomes this thing that's not really about whether or not you're healthy in some kind of objective or, some other kind of way. It's really this deeply contextual thing. So that, because we describe diseases in a certain way means that certain cures are going to work just because they fit. There's like this fit between what you have and what we do to treat it.
So we say you shouldn't feel this way, this will stop you feeling this way.
And then
so
you say,
well.
oh yeah, actually that really works. And there's this herbalist, this medical herbalist that I've worked with who says, we call it the placebo effect, right? And we put that to the side and say, well, that's its own separate entity. But in fact, so much of medicine is really about that. And I think that's exactly what we see in terms of COVID response, that there is a very particular understanding of what a pandemic means, a very particular understanding of what health and healthcare are all about, what they should be all about. And that means that, what you need is not the response that's actually going to end a pandemic or is rationally the most sensible. What you need is a response that meets those expectations in the best possible way, because that will give you this kind of, curative sort of feeling, right? Like that, we've actually done the thing that needed doing. And now we can go forward, whether or not that actually, I think, especially in the case of COVID, it's all the more explicit because after the fact, we've said like, well, why did we do that? Or like, did that actually work or did it not actually work? But it in many ways, it reflects, I don't know exactly. I'm not a health policy person, but I think following this historical trajectory, you can see the way in which the, flailing around for the right response has a lot to do with how you've defined the health and healthcare and all of these things to begin with.
So as I understand it, your analysis would sort of point in two directions. On the one hand, you'd say that this sort of industrial model plays a role in the terms of we sort of have this sort of national product almost, which is a healthy nation, and we have to have a sort of one-size-fits-all solution to it. And one can recognize that in the COVID response. But also this way of sort of this almost sentimental model of saying everyone has to, one of the things you get out of the machine that you put your life into is X amount of health. And, so the machine has to deliver that to you. And so in a sense, the question was posed in that way, and then these things had to be done so that the product that you'd signed up for, as it were, was delivered.
I think maybe one way, that's such a great summary, and like maybe one way of thinking about what's happened here is that we've had to confront the kind of paradox that operates all the time in terms of these two things, that on the one hand we embrace this industrialized way of doing healthcare because that's the kind of the best we can do in a certain kind of way, right?
Sure.
It's the the most health for the most people, or at least that's sort of the premise. But on the other hand, we still have this expectation of medicine being able to keep us healthy, make us live very, very long lives, and also that it should be caring and that it will be this very personal kind of thing, and that it will, all of the kind of attendant features. And you see that kind of, you see that all the time when you start to look in the history of medicine, that on the one hand there's this and on the other hand there's this, and these trajectories don't really intersect.
Right.
But we're comfortable with that.
Yeah.
Like, we're okay with that until we get something like a pandemic, which is this kind of very novel sort of experience, and then suddenly maybe sort of explodes on the scene this paradox, and then we're sort of left with like, wait, what do we actually want, or what are we actually doing? And in that sense, the pandemic is really useful if we take up those questions and actually deal with them.
Right.
But
Yeah.
we won't.
We won't. No,
Yeah.
I mean, it feels
But-
like we're basically stuck in a model of
Yeah.
COVID was something we had to beat. How well did you do in beating it?
Yes, exactly. Yeah.
Okay, so I think we could probably do our final question
Yeah,
now.
great.
So this is something that we mentioned at the beginning, and then you've touched on a few times, which is this healthy skepticism project you're involved in. So I think, firstly, it'd be helpful if you would explain what this is, and particularly explain this is for a non-academic audience who doesn't really know what we do when we're not teaching.
Yeah.
And when we get grant money to do things. And then tell us, then focusing back in on the subject of this podcast, tell us how the sort of skepticism that you're studying, as I understand it, could, at least in an ideal world or slightly better world, lead to a healthier or different or better COVID response to a COVID-like event in the future.
Yeah, okay. So the Healthy Skepticism Project really came from the idea that in my own sort of looking through of the history of medicine, as I've said already, you get all of these other practitioners, right? And the reason that we end up with one sort of mainstream medicine that dominates in much of the global north is not because that's the best system, but because it's the system that industrialization and all these other kind of factors produces, right? But my question was, well, what happens to those other sects, those other medical sects? So, there's this great one called the eclectics, and the eclectics believe that that it's not helpful to diagnose or to think about diseases. It only matters about how that particular entity interacts with that particular body. So it's deeply particularized, and it's very much about thinking about the body as the environment for disease, right? And I thought, like, well, where does that go? And I really became really interested in thinking about all of these people who critique medicine or who stand outside of it. And that was sort of its own sort of historical piece. So where do all of these actors go? And do we see them, anywhere along the way? But I think part of it was also kind of saying, like, well, when we tell the history of medicine, we need to tell it as something that's kind of a much larger entity. It's not mainstream and then, these kind of alternatives, but it's like a universe of alternatives, right? And then it started to kind of, applying that to the contemporary, started to kind of prompt questions about, well, what about people who are disenfranchised from medicine in particular? And, because one of the things that we saw over the initial parts of the COVID vaccine was this idea that people just didn't understand, why it was good for them. And if you just told them why it was good for them, they would obviously want to take it, right? But slowly people started to realize, well, that's not why people are skeptical, right? There are all sorts of other reasons. And that to me seemed to open up the possibility of applying this model, this historical model of a universe of healthcare alternatives to our contemporary and saying, like, well, actually, when you think about it, each of us is kind of our own sort of skeptic. We engage in our own skeptical practices when it comes to healthcare, insofar as, we go and we believe or don't believe what the doctor says, and we do, what they say, or we don't, or we do something else or whatever. Or we talk to a friend who tells us something different. but it was really interesting to me to think about, okay, so in the context of vaccination, but also skepticism more generally, there are, communities of people who are clearly sort of not just doing that very personal sort of skepticism, but engaging in something that's a little bit, more explicit than that. And so that led to a kind of sub-project within the Healthy Skepticism Project with a community group in Brixton, and sort of thinking about, okay, so this is a very particular community, a large Black community in Brixton. Brixton's a very particular kind of place, one of the first places that the Windrush generation settled, but also has this reputation as being this kind of, as our collaborators in the community health organization Centric have put it, it is this kind of counter public sphere. And so we got very interested in thinking like, okay, maybe this is a place where we can look around and see how people are articulating these kinds of views. And what I think came from that was that this kind of understanding that actually even now we live in this, globally definitely, we live in this world where there are many different health traditions that are, there isn't a mainstream that's right and then everything else. And in the particular context of Brixton, these kinds of, a wide array of reasons why people would be skeptical about vaccination, but even more than that, a wide array of alternatives to mainstream practice that people were really, engaged in and had really thoughtful reasons for doing so. And so the Healthy Skepticism Project then had this kind of contemporary sort of arm to it, very much through that project, but also through kind of this general notion that, well, we should, what if we didn't take for granted that mainstream healthcare is the only right way to do things? What if we used these views, these alternative views, to kind of think about if we wanted, and it's not even clear that we do, but if we wanted a really inclusive healthcare system, would have to be changed in order to get there. And I think, for the project itself, the pandemic really, articulated something that otherwise, the project would have been a historical project.
Because to be clear, the project was started before the pandemic.
It started, we had our first workshop in, must have been January. So a few months, January 2020.
Right.
So a few months before the lockdown.
And you didn't actually launch the pandemic in order to have something more.
I didn't. That would have been, yeah.
Sorry. Okay, so.
Yeah.
The pandemic comes along a few months after you.
Yeah, and so then it becomes something that, okay, so maybe there's application here that we can sort of think through and really try to understand where people who are, who kind of have been pushed out of the mainstream of medicine, where they stand on these issues and what they would like to see, in this country, the NHS do differently, or what they would like to have understood about the health traditions that they bring with them to this country, or their families brought with them to this country, that is not currently understood in the context of healthcare. And I think it's been really eye-opening in thinking about, I don't think I have ever properly thought about I've certainly thought about what in the theoretical view, disenfranchisement in medicine looks like. But I've never thought, what is it that we could take away from this that would sort of make things different? And I think apart from sort of this idea that, this notion that, healthcare is not a representative system whatsoever, and instead is really sort of authoritarian in terms of how it's structured and what constitutes good medical practice. As there has been nevertheless this kind of push for representation within public institutions, no less than within healthcare. So how do we do that? Do we even want to do that? What are the stakes? And I think it's also really kind of made it very clear that, again, in theoretical terms, I've read what you're supposed to read in a way about global health and how that all works, but thinking about it in terms of practice, it kind of really raises questions when you take these views and kind of make them sort of the kind of center and these other, the mainstream medicine is kind of the periphery, you start to realize that a lot of the policies that we pursue are, understandably local to our own national context, but also in many ways are damaging to the kind of, are not helpful in terms of global health and don't reflect at all the kinds of experiences and understandings of health that exist in other places. And I think the pandemic has really highlighted that, and I hope has highlighted that for more than just me. But it raises questions about, like, is a global vaccination campaign something that's worth pursuing, or is there something else we should be doing in place of this? Can we think differently? Can we think beyond some of these very kind of predictable traditional measures of public health to think about something that actually would be globally appropriate and useful? And I suppose the last thing to kind of say about that is kind of like in the, now that we've kind of, well, who knows if we've really come through the pandemic, however you want to, like kind of think about that, but that if there is an opportunity, if it has presented an opportunity for reform in the way that we do healthcare, then maybe these kinds of insights become really relevant and significant in terms of what that reform ought to look like. And just to give a very brief example, one of the things we've talked a lot about is the kind of nature of evidence and the kind of very specific notion that evidence needs to be of a particular type, done in a particular way, validated in a particular way. But what if you took, is there a good reason for doing it that way? The history says that the reasons are much more contingent than we might think. It isn't about some sort of recognition that data and evidence are the right way to do things and everything else is wrong. It's much more about these other factors that influence, that also influence the choice. But what if we said, well, we need to reintegrate testimonials, or narrative into the way that we think about what constitutes good evidence.
And good health.
And good health, right. Is there a space for that? Can we make a space for that within a system that, especially, the NHS, which is really, has, fallen apart? I mean, you've said, like, what would collapse look like if this isn't collapse in a way, right? Like, so, is this a moment in which we can sort of do that kind of work to reform? And so I suppose in that way it kind of has, the pandemic has influenced it, I suppose, in particular kinds of ways.
Right, so the instinctive reaction to these sorts of alternative models, really paradigms you're talking about, is to say, I'm sure they're sort of culturally interesting, but they don't work.
Yeah.
And medicine is about making things work that, make you healthy. And one of the things that, I've sort of learned a lot about as I've watched this unfold is the extent to which within our own, evidence, science, as we define it, based model with all our charts and graphs and peer-reviewed studies, we do so many things that don't work even on those terms.
Yeah.
That they have, treatments that are standard that either have never actually been shown to be effective or that have been shown to not be effective, and yet that keep going. But then also that we have this very impoverished definition of what to work means. It's just sort of this atomized, we're going to solve this problem, and it's defined to solve when it's this much better.
Yeah.
And then a much broader vision of what saying being healthy and helping people be healthier actually is one of the things we very much need.
Yes.
And in a way, this whole pathology was tragically reflected in the COVID as a problem to solve model that we've seen.
Yeah, I think that's exactly right. And I think that's a great point to end on, actually. Can we end on that? I think that was really good.
Excellent. Well, thank you so much for doing this podcast with us. And
thank
great
you.
to hear from you.
No, it was really good, and I look forward to our next session.
Yes, we will be switching roles, and I will be being interviewed by Caitjan.